panel discussions are innovative. It's a great benefit for anyone who takes the time to attend this meeting.
And there was a very practical handling of how to use imaging, how to make interpretation.
Also, it touches various topics, both on the coronary and structural side. Very insightful, exchanging scientific data and results of trials.
Several live cases have been performed to show complex, innovative procedures. Several workshops were So we move on to the next session, which has some very interesting live cases from Escorts Delhi and Mount Sinai, New York. So may I invite Dr. Prashant Kaul, Dr. Antonio Colombo, Dr. Gulio, Dr. Sanjeev Sharma, Chirag Bhaveshi, Pravir Agarwal, Vishal Rastogi, Ashish Jaikishan, Dilip Tiwari, Dr. Sandeep Mishra, Richa Sharma, Dr. Rajiv Rathi, Saurabh Bagga, and Omar Hassan. So we'll start this presentation with Dr. Gulio's lecture first, and then we'll go live to some Mount Sinai. So Gulio, we'll go first with your lecture presentation.
So thank you very much for being here. And the title is When the Chips Are Down, Imaging Bail Out Me Out. Story. Female, 77 years old, very fragile, with a PDA in story. And she went in cardiogenic shock with clearly chest pain, and this was the AKG. Echo with ejection fraction that was very low, and a mean gradient of a severe aortic stenosis of 60 millimeter of mercury. Then we check, it's not running. Why is not running?
Can somebody in the AV help out, please?
I think that we should be re-uploaded. So perhaps if we may stop and go in further, I will go to the preview room and try to fix it. Sorry for that.
So you want to see if the other one is also not running, or?
Okay, so this case, in fact, I showed partially in 2020 at CHIPS-CCO in India. It is a 91-year-old man who is quite good with his health. 24 years prior to that, he had mitral valve repair, and now he comes with a non-STEMI and preceding crescendo angina. This time he has severe aortic stenosis and LV function 35%. Given his previous sternotomy and age, he had 2 surgical opinions, were final destination in my state, and he was turned down by surgeons. In CCU, we discussed his case in our department meeting, and he was approved for Impella. This was only second year we were using Impella in Australia. So you can see he has quite severe left main disease. He has disease elsewhere in LAD and circumflex, OM, etc. Quite bad, actually calcified. He is 91. And he has severe aortic stenosis and LV function of 35%, and this is ACS. His right coronary artery also quite diseased, but we were not interested in that, given his overall presentation. And his options were medical or PCI, as he was surgical turned down. And this was a case I was doing in my second year after fellowship. So I got a structural consultant scrubbed with me because I'm not doing structural in case if we cannot cross the valve with impeller and we need to do BAF. And we had several access points. So the procedure was done via radial 7 French. At that point, we were not aware of 7 French via the impeller sheet. And I still wouldn't do it unless I'm struggling with access. And then crossing CVES. This is nothing interesting here. Impeller goes in. And on the right side, you will see I pushed impeller with some resistance and eventually it went through. And we immediately activated impeller, and since then we kind of don't have aortic stenosis, at least for our hemodynamics. And then I did LAD rota with 1.5. And then that time I was packing. You see, I came from fellowship. Now I don't do this anymore. I do Japanese techniques with much faster rota. Things always change in our specialty. So LAD was rotated, crossed, then ballooned. And I put a stent there, I think in LAD. Now next thing is trying to cross the circumflex. I had to use Crusade, and with Pilot 50 it crossed. And then did rota. Again, this is a packing technique. I don't do this anymore, and nowadays, if I did this, I would do it with extra support wire. There is no such a thing like I do only floppy, I do only extra support. For certain lesions, you need to change. But I did a lot, and eventually it crossed. Just for interest of time, I think I'll just move forward. But probably there was some injury to that area. We will see later. Anyway, it crossed after. And now I'm positioning stenting LAD. And the idea was to leave some ostial disease, stent proximal mid, and then stent circumflex to left main. Kind of avoid two stent bifurcation in this situation. And then stented LAD, preparing left main circ, no injections yet. And then positioning stent left main to circumflex, and then they observed the cloud. So patient was fine at this stage, and I deployed the stent, echo was requested. And when I came from fellowship, I didn't do much imaging. In Canada, we didn't do imaging those days. So it was without IVUS. So stent deployed, optimized, and two problems. One is bleeding, and second, I understood that the strategy was wrong, and I will need another stent for the ostium of LAD. So now there is one layer of stent in left main already. And the question is, where is he bleeding from? So I took a few more projections. And the question, is it rota-induced, or is it after 4-0 ballooning, after rota without imaging? So then I put a second layer of stent, kind of finished culotte. Left main now has 2 layers. Then kissed, optimized, potted, bleeding continues. And now I started to try to figure out where is the bleeding from. So inflating balloon in circumflex, prox, ostial, only when I inflated through the ostium, the bleeding stopped. That's kind of identified. It's probably in the ostium of the circumflex. Then I also inflated balloon through the LAD, but bleeding continued. So again, it confirmed that it's circumflex. So should I put, what should I do that time? I never experienced this. So I did balloon tamponade as I was taught. And by that time, echo already showed a significant accumulation, and despite impeller, he was already going hypotensive. So did pericardial tap, and this was my first autotransfusion through male-to-male connector to femoral vein. The fellow was just staying there and pushing blood back. So now we were with good ACT above 300, comfortable, that we now can think what we should do. So about 6 months prior to that, I read a case report from Germany, from Gerald Werner, who experienced a similar situation, and they put covered stent and fenestrated. So it's not something I invented. We had papyrus on the shelf, and this is 4x20 papyrus. But by the time I deployed that, I had my dual lumen microcatheter and Astata 20 and CP12 ready on the table. So when we deployed that stent, he started to have ST elevation anterior and started to become nauseated and unwell despite impelling. So Astata 20 is not the best wire. I don't recommend to use it because it has no tactile feedback. It just goes through that covered stent easily. But CP12 has good tactile feedback. I had to use it second time with a secondary curve. Otherwise, the wire was exiting. Then through trapping, I put Corsair Pro and removed the dual lumen microcatheter. When I removed, swapped to Workhorse wire and removed dual lumen Corsair, immediately with that flow, ST segments come down and patients start to become better with that 1 millimeter of flow. And then 1.5 to 0 balloons to increase fenestration, 3.0 balloon again through that membrane. And now it looks good. So now he has 3 layers of stent in the left main and 1 layer of stent in the ostium of LAD. In the original paper, they also put a second stent through the fenestration to keep those flaps, but I decided not to do that because I was quite happy with this proximal lesion kind of and good flow. The bleeding almost stopped. We then optimized covered stents and this final result. And this picture summarizes kind of showing that in the middle almost trifurcation, but it's a jet of perforation. So overall case took 8 hours, was quite a lot of radiation. The next day impeller was removed. 5 weeks later his EF improved, it was all hibernating. And now he came forward for treatment of his aortic stenosis by my colleagues. This was 5 months post PCI when he came for TAVI preparation. He had successful TAVI. We were living about 2 streets away from each other. This was 1 year. And then he developed CVMR. I don't know the mechanism of that. Maybe with the TAVI something happened, but he had mitral clip. We published this. It was one of the top downloaded papers in CCI with a schematic showing how to do that. 3 years later, his ejection fraction dropped. He became symptomatic with that. TAVI and mitral valve were good, but he improved on anti-heart failure therapy. He also used to brew his own beer, and maybe it was also contributing. He was drinking every day, but he was a very nice person, and he still drives the car at 95. Yep, final few slides. This is 4 or 5 years later. I brought him back when he had a drop of ejection fraction. Much the same lesions, OM was unchanged, right was unchanged. So I didn't do any PCI, and on medical therapy he improved. I did IVUS run, I did OCT run as well. Through that, I thought if I discover something interesting, it will be interesting to publish. This is IVUS and this is OCT. It will go now soon through the ostium of LAD here. MLA was under 4, but I left it. And last year, it was more than 6 years post-PCI. He was fine, no cardiac symptoms. I kept him on DAPT because of the papyrus in left main. And while gardening, he tripped over and hit his head, and he bled from that. So that was end of the story. And a few know-hows. What I think if you need to do that, before you deploy covered stent and block off that branch, quickly put a short stent in the ostium of that branch. That way you will be able to have it as a target for fenestration. We can also jail a wire, but wire will not tell you exactly where the vessel is. Second most important thing, do not pot. Because if you do pot, you will block off flow completely, and the person will become really sick. Without doing a pot, you still hope that there is this flow happening in the branch. And use dual lumen microcatheter in that situation, so you don't have a risk of wiring behind the struts. And do autotransfusion as well. And keep ACT high, above 300. Because if you autotransfuse continuously, you have plenty of time. You can do whatever you want. But if you give protamine and lower ACT, then it can be a problem. Thank you.
That's an excellent case. And Rustam, would you please join us here while we take one question? I think Prashant was planning to make a comment. And then we'll go live to New York. Can you please switch over to the live transmission? And
yeah, great
Prashant.
case and a great example of how to recross after placing a papyrus stent. Just a couple of questions, I guess. So when you had the perforation, just remind me, had you already placed either stent, or was the perforation before any stent was placed?
So perforation probably happened even before I put any stent. But the thing is, I tend not to do injections if patient is stable or no elevation, no chest pain. Just CTO, kind of how I was taught to work. But I placed LED stent. Maybe by that time, because I already ballooned that circumflex, he was probably already bleeding. And only positioning the second stent left main to circumflex. I did the puff just to make sure I'm positioning stent well, and that's why I noted for the first time.
Yeah.
And that's how we start get echo and quickly. Yeah.
So I was just wondering, in hindsight, whether you could have avoided the third layer of stent by maybe just placing the papyrus initially, and then. Yeah, but I guess we'll go to New York.
Don't hide. Come. All of you guys, come. Saturday morning we are here. They better know who it is. First, make sure they have to know that. You're 10 minutes late. You have to make that point. Let them learn.
Dr. Sharma and Dr. Kinney, you're live. And we have an expert panel, Dr. Antonio Colombo, Dr. Rustam Dattoo, Prashant Kaul, Sanjeev Sharma, Praveer Agarwal, and lots of other stars. So,
yes, we have seen, Atul, thank you very much, and of the organization of CHIP 2025 and CVT, give us the chance, and we are doing first time live relay in your meeting, and Saturday, welcome everyone. We are starting a little 10 minutes late, but you see all the staff. You know, we have full day Sunday. Sunday we have 34 elective cases tomorrow, but this is just for you. But we are happy to have it, and hopefully we'll go through a lot of educational points in our next 40-45 minutes. And you see we actually have 9 intervention fellows, and 2 of them are assisting today, Sophia Thang and Sabrina Kumar. And of course, in terms of our CVTs, all here, the Asif and Hakim, nurses, Will, Alina, and imaging is Kiski, which you'll hear. And of course, my main person on left side, Dr. Kini, which you all know. And we are ready to start, if as okay. And I know the extreme, very experienced, intelligent faculty, which will help us navigate through this complex case. If that is okay, we are ready to start. Okay, so
yeah,
this is yours,
Yes.
CHIP India. You can see it, you can hear us well. And let's go to the slides. Nothing to disclose. This is a 76-year-old male presented with dyspnea and chest pressure, has ischemia, and otherwise used to be okay. Didn't have any procedure before, good LV, various risk factor, but all controlled. LDL 45, CRP1, A1C actually now, today is 5.7, and LDL has even gone down to 39. Good creatinine, good medical therapy with a good control, because we all know now and that lot of emphasis has been done in both ACC and European guidelines on the post PCI treatment of these patients. It's very important that not just putting a stent alone is not enough, but subsequent treatment can decrease their further revascularization and further events. So basically, this patient had a cath about mid last month with a 2-vessel disease of the RC and LAD. RC was taken care. Syntax score was 21 and EF 58. And now today, and we'll show you that for OCT guided PCI of long calcified aneurysmal proximal and mid LAD using OA followed by DES optimization. I'm calling this as a O3 or O cube. And we show the case very quickly, but the appropriate point of view, ischemia, double medical therapy is appropriate. And you want to show the case first?
Yeah. So if you see, this is the
Go to the fluoro.
LV gram, EDP, probably diastolic dysfunction. EDP was like 18, normal, EF, and this is the right coronary artery, the PCI that we did from last time.
Flush.
Left side, non-obstructive, large
Flush.
circumflex.
Flush.
And then here we have the LAD. So this is something, I know there's a combination of old way of understanding before imaging. Is there calcium or no? We used to do dry cine. So you can see, even on dry cine, there is a tram track calcium that you can see in the prox to mid LAD. And this is the angiogram. So after the first septal, there is disease, and then there is that ectasia. After that, you see a diagonal that is arising that's totally occluded, likely from the level of that, from the ectasia, up to the second septal disease, and after that, on like 95% further down. Majority of the calcium is between the first and the second septal, which is involving that ectatic area.
So with that ectasia, Atul, we can take the opinion, and of course, Dr. Colombo, most experienced cardiologist of the world, is there, that would he use orbital atherectomy in this case? Because, you know, we always have been teaching that get away from tortuous vessels. This is aneurysmal, continue to play. Would you use orbital or just go with the rotational atherectomy? Continue to play that so people can see. Yeah.
Yeah, I'm... hi, Shamin. Very nice case.
Yeah.
It's a long, not severely diffuse disease. The lesion is relatively focal, but there is some additional diffuse disease. I would definitely consider rotablation. Personally, I prefer rotablations, standard rotablation, and so I will definitely do rotablation, and then to intravascular imaging, and then decide further.
Beautiful. All right. So clearly, as you said, that is what our usual teaching is. Now, can we deviate from the usual teaching and try to explore other part? And if you can go back to the slides.
Yep.
So we thought that maybe, as you know, that the only guideline so far has been in 2021 in the individual patient subgroups, basically, that both rotablation and orbital are 2A, 2B. Class 1 still has not made to in the calcific lesions and so. Now, these are the two devices, though have different mechanism. One, of course, the differential cutting at the tip, orbital, which is the orbital atherectomy, has an eccentric crown, which does cutting back and forth. And this is where the key is. Rotational atherectomy and orbital atherectomy, two differences, different mechanism of work in both of them. One goes forward only and does the ablation compared to orbital, which does the ablation both backward and forward. So I was the one who did the first case in December 22, in 21 in India of the orbital. And I know that orbital is being used in about 200 or 250 cases per month. Rota is still about 3 to 4 times higher because that's a comfort level. And this is where it works. Her techniques are a little different. As you can see there, one is the packing, go forward and come back. And a lot of people go very high speed fast, which is we still do not teach that. But usually is and compared to the orbital, you continue to go forward motion. Anu, you want to say something?
If you go back to the previous slide, I think how rotational atherectomy was first made by David Oth based on all the physics principle is differential cutting. And that is something I think we need to understand why pecking motion is so important. So differential cutting works, which means it only ablates the hard surface, which is calcium. It has to done in a slow motion. So pecking motion is very important, and which we teach at every time how pecking motion has to be done. And that is what people have to learn. What is the pecking motion? Because that is how rotational atherectomy works. Differential cutting, and that it works on the hard surface only when you do pecking motion, not the motion that people are right now talking. Keep going forward with a fast forward speed. That is not the way it works.
Yeah. And the second point is, which we all know, sometimes rotor burr can stuck because there is no ablative surface proximally. Orbital does not get stuck because it's both forward and backward ablation in the eccentric crown. But before the year end, we will have the first in man. We have designed the rotor now, which has ablative surface on entire crown, proximal and distal on the cone, and whether it will do better job or not on the animal day, on the ex vivo, I had done some work. Looks quite good. So let's go to the real case now quickly, just completing that this is orbital atherectomy technique, which is speed dependent. You do 80,000, give you 1.6 millimeter lumen. You go to 120, same burr, or they call it crown, gives you a bigger lumen up to 1.8. But we say 1.8 by definition is contraindicated because we use 1.8 in the past, 120K, and used to have perforation. Advancement is technique, slow 1 millimeter per second advancement, 20 to 25 second run. And even if you cross, you do multiple passes. Why? Because it's an eccentric crown. It will do ablation in various part of the segment. Technique, which one you prefer, we have published. I think overall can use either of them. Today is a little questionable. Angulated lesion, little tortuous with a, we'll but try very cautiously. And if need to be, we can stop just before the aneurysm. That's where we are. So, Anno, ready?
Yeah. So I think using this ablative techniques, which is especially orbital, rotational atherectomy, orbital atherectomy, understanding the device, understanding the technique is a key. And that is what we keep focusing on, how to do it right. Because one of the dreadful complication is perforation. So if you learn to do it right, you will safely do it in complex cases like this one or more cases that you see in your practice, and help more patients.
And this is shown very clearly. This is the advancer knob. Same, you lock it back and forward, and this is the you see the brake pedal, which once you're doing it, you have to press it so the wire gets stuck, does not move. And then these are the two speeds, 80 and 120. And I actually say that, remember, there was a mini crown with the speed was 40 and 80. To me, this is a very effective device. I think should not go beyond 80, but that's where you get into trouble. But anyway, we are ready to start now and advancing. Now, there are two types of the orbital wire. Viper wire is available. One is the Viper wire Advance, which is the usual one, and then called Viper wire flex tip. Flex is the proximal portion is more flexible, it tapers down, and this kind of case, you'll use the flex tip. That's what we have used, the Viper wire flex. And I don't know whether Viper wire flex tip is available in India, because I know in India they don't even have a rotaxer support. Only rotafloppy is available. Now, first you check the speed.
We're done.
Done. Okay, we are ready to start.
No.
Go. Back to same, push and pull. All these are over the wire devices, both rota and orbital. And so just slowly see the wire and the guide catheter movement.
One thing, let me just say, so before that, how would I wire this? So this is where it is. So you will go with your usual over the wire catheter, whatever it is. We use fine cross, and we took the fielder wire. So when you have an ectatic area, what's the concern? That usually your exit is not that easy. So at the ectatic area, fine to and fro motion, and we were able to get through. So this was the fielder and the fine cross. So this is the case. You cannot do primary wiring. Always use some other wiring and then exchange.
Dr. Samin, Dr. Hazra here.
Yeah.
You said at the very beginning
speaking.
there is a differential cutting. Yeah. Don't think it's a myth. If there is only differential cutting, there will be no dissection, no intramural hematoma ever in any angioplasty. we do
Very
see
good point. Very good point. Yeah, I'll tell you what happens. No, pull back a little bit. So key is that once it will cause differential cutting, but if your tissue cannot deflect back, like angulation, that's where you get a dissection perforation. So key is the phenomena of deflection of the elastic tissue does not apply all the time. You're right. When we say nice lumen with a rota and orbital, this is a theoretical. 70% true, other 30% not true, because if the vessel is angulated, so it will not differential cutting because it cannot reflect, it cannot deflect. It will still remain in the path of the vessel or path of the burr.
Yeah, Dr. Hazra, other question also is, remember when in our algorithm, we always say moderate to severe calcium. So if imaging is used and people want to understand, if you have 90 one quadrant, 2 quadrant of calcium, we always say stay away from atherectomy. That is where I think many times you see that no matter what we say, how it behaves in the body is a different story. That is why when you are doing it, it may not deflect and cause some dissection. So it works the best when you have severe calcium, which is 3 quadrant or even 4 quadrants.
And you know, all the new trials of, just want to complete the sentence also, that all the new trials of IVL require that you do imaging, your calcium arc has to be more than 180 degree.
right. So when
We are
the
ready to start now.
when is your imaging catheter is going to come out from your pocket?
Little later, after that, as Colombo said, do the ablation, then we do imaging.
Okay.
Yeah. Okay. So this is 1 millimeter per second forward. Now, it's a machine will make a beep at 25 seconds. So you have to have that control that how many seconds forward you are going, because you have to then pull back. Because it's going to do ablation both times. So you think about you advance like 12, 15 seconds and then start pulling back after that, because 25 seconds you'll hear the beep. And that's what we are going to do now. Anu is going to do. Start pulling back.
So device pitch will be your endpoint.
25 seconds.
Because
Yeah.
you're
We're still going through it, yeah. So it's still far away, but
I
same.
think we
Always
can
after
talk
some time, the hemodynamics you are seeing that blood pressure should not go down, because that's the precursor for slow flow. If it's down, we actually will, and our nurses will give neosynephrine, 100 microgram or 200 microgram bolus. Now see, it slowly has gone to that lesion.
What will be your endpoints of effective calcium modification? Is it the sound, the passage?
Very good point. No, in this one, just once you crossed it, same. So both of them, key is that whether rota or orbital, that once you have gone through and the sound does not change, and then you do a few polished runs. But advantage with the orbital is that during even polish, you will do some ablation compared to rota, unless you change the wire tip. Make a rota in eccentric direction. It usually just does not give you any additional lumen, while multiple passage with the orbital will give you, just show one at 25 second noise.
oh,
Yeah. So, okay.
why is it not making?
It
I'm
makes
stopping
25
before.
seconds. 25 seconds. Now, see that we've gone through. This is a 2 times. Now going to go again. And you're going to hear the noise this time. Keep going a little more. You have to go further. Yeah. You start pulling. Yeah, that's the noise. So that you have to coordinate. Yeah, now is too much a little bit, and then
Okay.
pull back the same. Good. Ready? You want to do one more?
No,
Okay. So now same, although there is the
lock it.
lock. Now we have to release the lock and lock your advancer knob and just pull it.
Don't you do the thing?
Yeah, that also, the glide assist.
Yeah. Yeah, now it's glide assist.
Yeah. So see this, which is
Okay,
basically,
Advance wire.
yeah.
Get this.
It helps.
Run through wire.
Yeah.
Can you show the ceiling camera? That is a glide
Okay.
assist, just like we do the Dyna with the rota. Initially, it was not there. Later on, they upgraded it. Version 2 or 3, they have a glide assist.
So, Dr. Kinney, don't
Yeah,
you think that
overall in the yeah, sorry.
Eclipse trial has killed the orbital in US because Ajay Kirtania is from your country?
Yeah.
Agree?
Yeah, I'll tell you the numbers latest. The latest numbers are that we have. Let's take a picture now. So
Okay.
we are taking the picture, and I'll tell you on that issue.
No, in Eclipse,
Very good.
Eclipse study also, there where they did the imaging, the results are better as compared to over orbital atherectomy rather than NC balloon. So,
Yeah, no, but only one problem is
imaging
listen
guided
to
is
that
better.
part. Absolutely correct statement that imaging gave you better MACE rate, but it still did not make significance. But what has happened is, even with the imaging, the complication, there were the two major complications occur in the trial. Slow flow and perforation did not change by imaging. So that's the one of the concern. Now, let me tell you what has killed the orbital or rotational, IVL. Right now, the latest data of the ACC NCDR, just like every PCI registry, every case is submitted to the National ACCA registry, and they keep giving you the up-to-date every quarter, your data compared to the national. So last quarter data, which we got in the first quarter of this year, at present, there are IVL is used in 9% of PCIs. Rotational atherectomy is used in 2.1% of PCIs and orbital in 0.7. So significant drop. 2 years ago, the orbital atherectomy was 2% and rotational atherectomy was 5%. So there, yes, I mean, it has not been completely killed. It's on resuscitation measures, maybe getting little epinephrine and little CPR. Yeah. Good.
Okay.
So wire has been go side by side. This is the now let's
Where is
open.
the yellow?
Yeah.
While you're doing that,
do-
Dr. Sharma and Dr. Kinney, this is Prashant Kaul from Piedmont in Atlanta.
Good.
Nice case so far. And I just wanted to point out something you guys just did there, which is something that I do as well, which I think makes a lot of sense, is just rather than switching out the wires at this point, you've put a parallel wire. And then I presume you're going to do your imaging and other things on that other wire in case you need to go back with orbital and so on. But it makes
That is
sense just
correct.
to do a parallel wire
Yep.
there and quickly check on that wire.
So yeah, very good. Two things we'll do with this. The balloon going to do some additional, I would say, modified one wire scoring, and the second is and the second is that if you need to go, only problem is the orbital. I would not go with 120. Rota, if you need to, and you think you have not created a cracks, then you can go to a bigger bar. But orbital, I would say 120. We are away. Let's say if I did a last 100. The OA, probably one case, we did 120. But yes, very good point. So it's going to do two things. Basically try to look into the cutting balloon as well as advantage for you to upsize your or change your modification strategy here. Yeah.
OCT
So,
ready.
This is the 2.5 and we have the OCT ready. Yeah.
Dr. Sharma, while you are doing your imaging, we are just going to come back to you in 5 minutes. We are over to Kirti Punamia, who's ready to show what he has at Escorts. Can we switch over to Escorts, Fotis?
No. Listen,
but let's show the OCT. Guys, we always say,
And
Yeah, Kirti, can you hear us? Can you switch the audio?
Hello,
Yeah, Kirti.
can you hear me?
Yeah.
All right, so I'll be very brief. We have a lady here on table who's 71 years old, and look at her coronary. Can you see the screen?
No, we can only see the.
Show them the angio.
Yeah, so we need the screen to be shown.
Show them the angio. Yeah. Can you tell us when you can see the angio screen?
No, we aren't seeing the screen.
Someone needs to show
Yeah,
them
now
the
the screen
angio.
is there. Yes.
So we have this, can you see this heavily calcified proximal mid-LED lesion, which has a very large diagonal coming out early in the LED. And then that LED takes an acute bend, calcified, heavily calcified to a tight lesion. Show them the epicranial. And this is the epicranial. So you can see the LED turning upon itself with this huge eccentric chunk of calcium that you see. There's a diagonal branch, and then beyond the diagonal branch, the calcium extends a little bit, and then the LED is okay. So this is the lesion. You'll want to discuss it for a couple of minutes, and then I can tell you what I've done.
Yeah. Any comments, Prashant?
Yeah, Kirti, hi, this is Prashant. I think that there's obviously even on just the fluoroscopy, there's a big shelf of calcium there, and it extends right up to the ostium, just sort of abutting the distal left main. You've got a large ramus there as well, which I think you've got to be careful about. But doesn't look like there's any disease in the ostium of the ramus. So I think, a lot of the initial questions will be answered by imaging if you're able to get an imaging catheter across, and that will determine your strategy in that proximal LAD segment. And I guess the question is, what level of calcium modification are you going to need there? Are you going to need atherectomy, or is it something you're going to be able to just manage with scoring or cutting an IVL? But I think the imaging will be a good first step.
Rustam, you have a comment?
Yeah, I think the proximal ostial LAD is not the biggest vessel here because it's kind of mixed system, almost like twin LAD. So the question will be, is it 3 or 3.5 vessel for the left main? I don't think you can do ostial PCI here. You have to do provisional to left main, and that's why it's important. I would do rotablation first with 1.5, then do imaging, and then decide what's next.
So if you look at the caudal view,
so how many people think that the imaging catheter will cross?
I haven't seen the caudal view.
Yeah, Kirti,
Okay.
will you show the caudal once again? Yeah, LAD ostium is normal. The diagonal is early, but there's a segment of normal LAD. Do you have the RAO caudal view on this? Yeah.
So the RAO caudal actually overlaps, so you can't see the bifurcation.
Yeah. So there's a short segment of ostial LAD which is normal in this
Okay,
case.
so there is a landing zone.
Yeah.
Oh, in that case, I would just do rotablation 1.5, or if you prefer, you can do orbital here, and then do imaging.
So Kirti, why don't you quickly tell us your plan, and then we'll go back to New York while you finish your case.
Very quick, my question is always put an IVUS catheter when you can, and so I did an IVUS catheter. How many people think the IVUS catheter will cross?
It's a tough call because it's a very tight lesion and calcium is significant.
So just show them our IVUS catheter where it went. So our IVUS catheter went in without much ado, and if you can show them next. We got in a wire. We had some challenges to take that acute bend in the LAD in the wiring. And then next, we got an IVUS catheter down there, and show them the IVUS because that is of interest. So we did an IVUS. Can you see the IVUS screen? Atul, can you see the IVUS screen?
Yes, the IVUS. Can you enlarge that? We can see the IVUS. We can see it now clearly.
The IVUS shows that that's your distal landing zone, a little bit in the mid LAD, and you'll see a diagonal coming. You'll see the lesion coming up. So you have a little better normal area again, and then you coming very close to that calcified lesion, which is fairly discrete in that sense. But here it starts. You can see a slit-like calcium with two walls of calcium hugging the catheter at the level of the branch. And then you can see that there is a little more eccentric one-sided calcium or 180 degrees, sparing the lumen well. That's not my challenge. And then we have this area which is the where it merges the proximal LAD, and then we can go into the left main right here. So we could potentially put our stent at the LAD ostium and go forward. We don't have to really cross it over to the left main if we don't have to. But my question is, having seen the calcium, show them the calcium. We'll just go manually to the calcium again. Manually to the calcium.
Yeah.
What do you think is my device? And my IVUS catheter has gone. So what do you think?
Dynamic review.
But it looks worse in angio than on imaging. And imaging is not so bad. I don't think retrospectively you need rotablation. I believe you can try with a high pressure balloon, or if you want, you can do IVL, but depends on the cost. But I think a high pressure balloon is reasonable.
Yeah, I think the other point here is that, at the worst point of the calcium, you had a nice concentric ring that should be fairly receptive to IVL. If you do decide to use atherectomy, which I don't think is wrong, I think it's dealer's choice. I think you could go with either rotor or orbital. I don't think there's I didn't see any eccentric nodule or nodular calcium that would push you towards orbital. So I think either atherectomy strategy would be quite reasonable, and you may or may not need to follow up with IVL afterwards.
So and I think the information that you got from these IBUS, if you use rota, I believe you can even start with the 175.
You took the words out of my mouth, Dr. Colombo. I think a 1.5 would be like flying through the lesion and wouldn't have much purchase on this lesion. So I started with a 175 in these cases where IVUS goes in and there's so much calcium fluoroscopically, and you can see slit-like calcium. 1.75 is the right bird to choose probably. And so go next, please. We decided to go with next. Oh, here we got a 175, and you can see that we've gone now to how many minutes of rotablator so far? 2 minutes and 55 seconds, and we've gone to the next. Play that. Let it go. We've crossed the most calcified lesion over there, and there's one spot, that distal spot right near the branch, which has calcium on both sides. We want to take our time. We want to ablate it slowly. We'll work on this. We'll let you go to the other lab. Let us work on it, and we'll have more information for you once we've done rotablator and make other choices for this person. Is that okay?
These cases usually require 2 devices. Empower trial or roller coaster trial. Only rota is not good enough. So you have to have some imaging after rota. The second device, the need for second device is almost 20 to 30%.
Yeah, maybe the other option is that you downsize your rotabar and then try and cross. Yeah. So, Kirti, have you any further recordings on this, or can we come back to you in another 10 minutes?
Perfect.
Okay, so we'll go off to New York, switch over back to Dr. Samin Sharma. Yeah. Dr. Sharma, we are back with you.
Yeah, but you remember what we always try to say, that by this interruption, you lose the audience what to do. We always say, you do one, even you want to do a 15-minute continuous transmission, one center, and that's the way it should be. I'm always telling, even ACC, TCT, we told everybody, do a time, you give 15 minutes if needed, 15 minutes fine, but should be continuous in one place. Anyway, let me just control here now. Let me show what we have done so far. We dilated after OCT was done, and they'll show the OCT run. Why don't you show the OCT run?
OCT essentially showed calcium like we had seen before that area, 360-degree calcium at that area. So 2.5 balloon actually expanded, but we went with a 3.5 cutter. So this was a 2.5 balloon, and then you see that just after the first septal vessel, this is a 3.5 cutter, 18 atmosphere and 48 stent. Now the distal vessel is 2.5. We put a 48 stent. We put a high pressure 3.5 at 18 atmosphere at that area, and now we are ready to do the OCT. Let's do the OCT.
Okay. All right. So ready for the post-procedure OCT. We are not post-dilated. The wire a little further. Post-dilated the mid-segment, but proximal segment has been post-dilated with the 3.5 at 16 atmosphere. Whether subsequent need to be done, we'll see. But this is it. This is it to show what we have done so far. Combination of live OCT, please.
Yeah, we can check the path.
Wait. He has to tell us.
Mm-hmm.
Good. Okay, go.
1 second. Enabling, calculating. Yeah, Cine inject.
Go.
Yeah, great image. You can take it out.
All right, Kiski, teach us what's going on. What do you see?
Sure, of course. This is both stent. We do angiocorrelation. This is the Abbott Ultron 2.0. We have a calcium detection and the AI integrated the lumen-like area measurement. So now it's calculating angiocorrelation. Confirm. Okay, this is a post stent. So I go through the distal. Now, yeah, it's the edge of the stent. Actually, there's like slight intimal dissection at distal edge. Coming to more proximally, yeah, stent looks like circle shape, like well expanded. And I see a lot of dissection, but it's behind stent. So we cover the dissection by the stent. And proximal more expanded. Like this is the level of the ectatic part. Of course, we cannot like oppose perfectly, but stent is well expanded. And now come more proximally. Yeah, our tightest 360 cos part expanded really well. The area is like 9.5. It's really expanded.
And the proximal edge.
Yeah, proximal edge also looks like no major dissection, but looks like slight intimal dissection. So for the distal edge and proximal edge looks like some slight dissection, but stent is well expanded. Of course, the point of the MSA is like not that high because of the small vessel. I can measure manually because sometimes it's not.
Yeah. MSA is okay, and even the dissection based on, I know there was some discussion based on the OCT criteria, it is still intimal. Angle is very less, right? So not more than 60. We can leave alone the distal edge as well as the proximal. I think we are seeing it because we have the OCT. Angiographically, everything looks good.
Let's take a better picture with the angiogram now. I give some visuodilator. Let's take one more good picture, then we decide what to do distally. Because I think the proximally everybody agrees, very nice lumen expansion, stent expansion. Okay.
Go.
And remember, this vessel has some disease downstream even before. Let's find out from Dr. Colombo and Dr. Atul and everybody else, all the experts.
Antonio,
that's what you do.
What do you think in this the original disease? Would the drug-coated balloon would have been a good option?
In our experience, we have drug-coated balloons available for de novo. In this lesion, I would consider a short stent and a long drug-eluting balloon. We do this procedure with a pressure wire monitoring the distal DPD. So I think, but in United States, you cannot use the drug-coated balloon for de novo. So I think this is the standard approach that we have utilized for years, which is okay. But now we would use the drug-coated balloons in these situations.
Angiographically, the proximal LAD also catches your eye a little bit. I wonder if we could look at the imaging of that segment as well a little bit.
Good. Let's see the before the stent, Kiski.
Oh, sure.
Okay, that's on the wall there outside.
I come back to the initial IVUS.
Let's show what we see on the OCT proximally.
Yeah, so this is the initial IVUS. I mean, after the OA. So this is our like a tightest 360 cosmple. Just after the OA, the surface is shaped, but no like flexures. But after that, like a huge like dissection. This is just after the OA, like multiple dissection.
So then we should put a stent proximally also.
No. Hold on. Please go back. Bring that thing there.
Yeah.
Now go back to the proximal edge. You showed us before. Go back to the proximal edge. Yes.
You mean post-stent?
Post-stent.
Sure.
Yeah. Don't go what was before.
So this is a post-stent.
Yeah. So now let's go. Okay, it's only intima, right?
Yep.
And can you give us a measurement of the?
Maybe anyway, it's like a 20, 30 degree.
Yeah, it's only 20, 30 degree and not even 2 millimeter.
Yeah. Longitudinally very like focal. Or might be some side lunge.
I would leave everything alone, proximal as well as distal. What do you think, Kiski?
Yeah, it's not a major dissection at the proximal edge of the stent. So in the point of view dissection, we don't need to cover.
Gulio, what is your opinion about
don't need to cover.
The dissection in the OCT? What's your opinion on that?
More than the dissection, I wanted to move the proximal reference exactly at the point where you can see the EL, the proximal reference. And
you want to go back to show the
go back to the most proximal segment where you can see the EL. You can see here. That is what the people were alluding about the proximal segment. You can see that the lumen for the proximal ostial LAD is 377. That is very small. So and that was the question that was addressed. I'm watching to the angio. I seen that the true proximal part is a little bit suboptimal. And then now we needed to deal with a good results inside, but the proximal part of the LED is with a small lumen. Normally we try to achieve 8, 9.
Go back.
And
Go
here
back
we are
Proximal
377.
That is how
Yeah.
much?
Around
MSA?
here is some.
Yeah.
well,
Yeah,
it's
but
true.
that is, we never
I think
planned
we
to
put a
go to that
3.5.
area. No, they're talking
15.
the proximal
Yeah.
LED, which we
Yeah.
never focused on.
Yeah, but now there is a lumen
we
there.
can
There is
always
a disease.
Go
we
back.
can always leave it as it is and bring back in 2-3 months for stress echo. But almost no doubt at some point there will be staged PCI to proximal LED.
Yeah. No, I
So
think
what's the
it looks
MSA
very
that?
important other
Proximal
side.
LED? Oh, 3.1.
Cross section area is 3.1.
Okay, so it's two different criteria we are talking. One, as far as the dissection is concerned, I don't think we should do
Okay.
anything because this is the teaching point. Okay, putting a stent is very easy. What we need to teach is when not to do additional stenting. And I think based on imaging and angiography, there's no need for additional stenting.
No, no,
But now,
proximal lumen is tight.
no, that is different. We are talking proximal stent edge. Proximal stent edge is okay. Now we are talking the stented segment, the proximal LED, you want to make it normal, then it's a different story. We are just talking
Yeah,
the
that's
area of
exact-
interest, the area that we intervened.
That was exactly the point we're making. I think the proximal and distal stent edges you could let go, but the proximal LAD segment where there's de novo disease, that was the question, and your OCT image shows that now.
I mean, other option is you can bring
FFP2 or
patient in
follow?
2-3 months time for stress echo,
Yeah.
and if necessary do angio, because that way you will assess your distal age. Because distal age, that's another problem with some disease.
Actually, you can reclassify the proximal segment prevent-like lesions or non-prevent-like lesions. If you have FFR, which is positive, it is a non-prevent-like lesions. If the FFR is negative, it is a prevent-like lesion. You can just leave it.
But I think in this case, there is a reasonable, it's a quite narrow, if you look into it, angiographic. Let's say you don't have imaging, you don't have anything. I would say if this patient comes here with angina, you probably will put a stent proximally. So I think nothing wrong in just putting a 3.518, another Zions stent, but that's a minor thing. But I think we had a very good discussion. We don't need to do anything for the dissection, but there is a lumen is decreased proximally. And every view shows eccentric 70% lesion angiographic, confirmed by the smaller lumen on the OCT. And we just put one extra stent. And if that is okay, Atul, I think we can conclude our presentation from here. And you go to Kirti on your completion of your other case. But we went through various points doing orbital atherectomy, optimization with the OCT, so that O-cube concept has been implemented in today's case.
So would you consider doing an FFR before you leave the case? Any one of you in the panel?
No, I would say that I would put a stent.
All right.
So-
You ask other faculty, tell us what they say.
If you decide to put a stent, will you nail the ostium or you do a crossover to left main?
No, nail the ostium. Definitely, we don't want to make further issues there. I would, I think there is enough room. There is enough room there. Yeah.
So, Dr. Sharma, in support of the fact that you can potentially leave it, is this plaque is fibrotic and fibrofatty. It's not purely lipid. So you don't have, I'm talking about the proximal part. And so you don't have a very high risk profile to get destabilize this plaque. So this is something that could be taken also into account.
All right, so Atul, take the vote of your panelists, yes or no, and then we just conclude it to follow what we need to do.
All right. So let's take a raise of hands. Who would say treat the LED proximal lesion now?
How old is she?
So there are 1, 2, 3, 4, 5 hands.
Dr.
They
Atul,
say now.
And how many
what else I would definitely do in my case when I did it in Australia, I would definitely do DCB, blended therapy to the mid vessel because this is long and now about to put a second stent. Long stents at outflow is not good. It's limited outflow. So in US you cannot do that, but in Australia I just put DCB, 30 or 40 millimeter DCB there for 3-4 minutes.
I think both distal as well as proximal needs a stent. Distally small and proximally around 18 millimeter.
I think we are getting.
So,
I think
Dr.
that
Sharma, you'll have various
I think we just
opinions, and
consent.
there's so many people with different minds. But what you have done
But
looks
that's okay.
very nice.
That tells you that more than one right way to do. I would only say, Atul, and I know a lot of people wanted physiology. We know that this case has a positive IFR and FFR now because of do you see the LAD disease? And this is what we learned from various trials, that do we need to eliminate entire IFR, FFR and normalize versus you do what we usually do, particularly in this particular case, is LAD, diffusely diseased, distally or moderately diseased, FFR, IFR, both will be positive. So I think the way you said 5, yes, and how many were no then? How many in your panel and moderation?
Sir, Sanjeev here.
Total people.
Sanjeev Sharma is taking the poll and he's making a comment now.
Yes, sir. Majority of panelists are opining for FFRs before finishing this procedure. So let's do an FFR and have a clarity about the significance of ischemia.
Yeah.
If it's
So
negative.
final call we'll leave to the operator.
Yeah.
He's the best person who's taking a decision. But we've had a great discussion, and this lovely case, and it deserves a big hand, Dr. Samin. Thank you very much.
And Dr. Keeney will say exactly what to do. What do you want to do?
No,
Medical therapy.
I will leave that everything alone.
Okay.
No FFR, no more OCT, nothing. Leave the patient alone.
And call back.
They'll do fine.
Okay.
Wonderful.
All right. Thank you very much.
Thank you. Big hand for you. Thank you very much.
Good.
So we move back to Fortis
Okay.
Escorts, Delhi. Yeah. Kirti, we are back with you.
Thank you. So, we did just show them a couple of runs, go back a couple of views so that we can show them what we did and get them to speed. So here we had the rotablator, 1.75, and we kept it at 185,000 revolutions per minute, then we went up to 200,000, and our total rota time was 7 minutes and 22 seconds. And we did multiple runs of 20 to 30 second runs. Eventually we got a crossing, and then we did around the last 2 or 3 runs were at 125,000 revolutions per minute. And post that, we've exchanged our wire now. If you're seeing our current, we've got an IVUS catheter again, and we're going to show you your post rotablator IVUS now. So if you all want to be with us, that's what you'll see. So that's your artery there. If you can see the IVUS, have a look. Oh,
Yeah, we can see it clearly, yes.
Okay. Okay, great. So that's your IVUS pullback coming. You can see that the distal landing zone is around 3 millimeters. Whether you take the EL or lumen is almost the same.
Can we make the IVUS image a little bit larger?
Yeah, can we cut off the lights
thank
because
you.
there's an electrical noise? You can't make it any larger than this on the screen though. But,
No, it's okay. It's okay now.
Yeah, so here we are. A very nice landing zone. Put a bookmark there, please. And that's the area just above the calcium. And you'll see a branch coming in. You can see that split-like calcium which was there. Can you see how it's been cut? Can you see those 2 layers of split have gone far apart, almost 2 millimeters apart? This was like a narrow slit. And now we are left with just this eccentric lesion. And I believe that if I take a 3O cutting balloon, this should be good enough to manage this. So a rota 1.75, 7.2 minutes of rotablator, followed with a cutting balloon with a rota cut strategy. I think I should be able to get away. And then probably our stent strategy will determine either nailing the ostium or even going across. It's not a big deal. That's it.
Praveer, any comments?
Yeah, see, how many of us think that cutting balloon in such a heavily calcified vessel is a good idea after rotational atherectomy?
3O.
Why not a high pressure balloon?
3O Wolverine.
3O10.
Kirti,
Why not OPN?
Yeah, why not this? Why not that? But I think I'll do what I think I do.
No, OPN is the poor man's IVL.
I'm not a poor man. I don't want to be poor here. I just want to do what I do normally in my own cath lab. So I will just do what I do normally in every day. I don't want to deviate from that. For me, the strategy is rota and
But
cut.
if you want to expand your stent, you need fracture of the calcium.
No, on IRF, you can see multiple areas of fracture. This is a great rota run, and I think I really liked one thing that you did. That you went with a low speed. You know, there is a lot of data that if you do a polishing run with a low speed, either 120 to 130, you will get 0.5 millimeter more gain in the lumen. So 1.75 bar, which is very well sized in a 3035 vessel, and you went with a low speed, you almost gain a 2 millimeter, almost made it a 2 millimeter rota bar. I think that's a great atherectomy. And what balloon you want to use it, it's a dealer's choice. You can go non-compliant, you can go whatever. I think operator is comfortable. It's well enough.
Exactly. I think the choice that we make beyond the rotoblader, whether we use a scoring or a cutting or an NC, I think it's a toss of a coin and the choice of the operator. And because I'm operating, I have the veto of my choice. But we'll just do what we think we do every day in our cath lab, what works basically.
I think we are just forgetting the villain here. The villain is the calcium. It's going to come back again and again if you do not kill the villain from the very first time. So killing the villain by rota or IVL or any other additional device, I would say IVL should be ideal here because you have to kill this villain right now. Otherwise, it will regrow, will take a rebirth inside the stent.
Kirti, you'll get a lot of advices. Please do what you think you are wanting to do.
I like to listen to everything, but I'll do what I do every day.
Yeah.
And I respect everybody's opinion. I mean, I'm not being arrogant about it. I just want to do what I do in my own lab. That's it.
I think the calcium is already cracked, so I don't think there is any point of using IVL or OPN. I think Flextome or Wolverine is a perfect choice to get better stent expansion and less of recoil. The calcium is already cracked after beautiful ablation. Why do we think that we need a IVL or a OPN in this case?
4, 5,
So,
6,
Kirti,
7,
while you
8,
do the
9,
cutting
10,
balloon and another imaging, can we take a brief break over here and do a talk?
So this is a 14 atmospheres, 3/6.
Wolverine.
And give me an RO caudal. We'll show them in two views whether it's opened up. Come to RO caudal, please.
So this is 1:1. Is that correct? 1:1 cutting balloon.
1:1 to the distal lumen. Yeah, go up to 16. Thank you. Down.
So we are going to take a short break. And Gulio, are you ready with your presentation?
They're going for a presentation.
Let them do. Yeah.
One thing
you guys
which
do what you think is right. We'll do what we are thinking. Whenever you want to come in, you can come in.
Sorry?
Go ahead with your lectures, and whenever you feel like coming into the cath lab.
Yeah, no, just a short break, and then we are back.
Yeah, please do that. Please do that. Yeah. Go ahead. Okay.
Over to you, Gulio. Your presentation.
2, 3, 4, 5, 6, 7.
We were saying that it was a fragile lady, 77 years old, with PDA, and she went with chest pain and in cardiogenic shock. Here you can see the AKG, and then echo was done, and in echo there was clearly an extremely reduced ejection fraction, plus the evidence of severe aortic stenosis, and the gradient, the mean gradient was 60 millimeter of mercury. Magically now the video are running. So we went to the angio, and well, the first approach was showing the ostium of the RCA with calcium around the aortic roof and quite tight. But we were very reassured by the first aerial view on the left main with some moderate disease at the distal part, and then we switch the view. And when you switch the view, you change totally your assessment of the left main. Huge calcification extending from the ostium and or immediately after the ostium are going down into the LAD. So now the situation with the lady in cardiogenic shock is what to do first, having a heavy left main and right coronary ostium calcification, and the lady in cardiogenic shock with severe aortic stenosis. Where to start? And we decided to bring first to try to open up the valve So this is a small safari wire inside, and so we did a valvuloplasty at the best we can with sizing was 23 for 45 millimeter balloon. And we achieved a quite significant result. The gradient went significantly down, and the patient was started to feeling better. But it was not totally solved, and the next morning we bring back the patients. We try to keep simple the approach to the right. It was an osteal lesion, and we don't want to make any dissection going back into the aortic roof. So we use 1.5 burr, then a 2.5 non-compliant balloon, and we end up with a DS 3.518 post-dilated with a 4.0. Then we went to the left main, and the point is, in my view, very clear. You cannot handle this type of situation without having imaging. First of all, you can get doing baseline, and it was shown by Curti the value of the baseline imaging, and perhaps we miss from the MANSAI the value of the baseline imaging to orient the strategy. And here is what you can get with the modern technology. You can have the usual imaging, but you can have measurements. And the measurements inside are showing that the distal reference was a 3.3, so you downsize, 3.25 is okay. Then you can get the length of the lesion in the proximal part. You don't see the EL, that is the tiny white line in Altreon 2.0, and you need it to be based upon the lumen. So in this case, it's easy to switch with AI from the most advanced measurements guided imaging to the normal ones. And here you can see clearly the different type of calcium that you have on the different segment. The spots were completely different. In the left main, you can see 2 plates of calcium confronting. Then you have a nodular protruding calcification on the proximal LAD. And you can take also the measurements to be oriented in the type of technique. We took the minimum diameter and the diameter at the level of the nodules, and also the thicker of calcium. We decided to go with a burr 2.0 at 160,000 read per minute. And here you can see the procedure. You can get some information if you're using imaging immediately afterwards. Single pullback, 75 millimeter, 2.5 second. And you can see that there is some clear effect, plus some also impact on the marginal procedure with some small dissection and some smoothing effect where the rotational atherectomy was working. We achieved some significant improvement in terms of lumen area, but of course, we cannot say that that is a good result for finishing the procedure. And here we decided what to do. To go immediately to the stent, we were not considering to go to a high pressure non-compliant balloon, but the thickness was still very significant. To add to the rotational atherectomy, the cutting, knowing that you can get much more deep fissure when you are smoothing the calcium superficially. The minimum calcification is becoming in imaging more and more important for making the decision. We went with a non-compliant balloon that segmentally, focally, with a cutting balloon at the proximal site and the distal portion of the left main, and we finish with a non-compliant balloon later on. The stent, 2 stents were placed. Distally, you remember, 3.3 in terms of EEL. We downsized 3.25, 23, and then based upon the EL at the middle portion of the LAD, we finish with a 3.538 stent until the ostium of the left main. and then a post-DIL with a 3, 5, and 4. And then once again, after this procedure, you check the results seem good from an angiographic point of view, but it's very important in this type of a very complex lesion to go to the final assessment. And in the final assessment, we achieve distally a good MSA, but you can see highlight in orange in this advanced imaging that there is some sort of underexpansion in the proximal LAD. Here you can have the level of expansion if you are taking entirely from the proximal ostium to the distal, not in a dual modality, the assessment, the automatic assessment. But normally, when you have a major bifurcation, you need to split in two parts. And in fact, going in, you can see that the proximal part of the stent is not only malapose, the proximal part is on your right side, but is also clearly underexpanded. We went back based upon the measurements taken. We finished with one 4.0 balloon, 28 atmospheres. This is the results, and this the final results achieved with angio. And you can also compare with this modern technology the baseline assessment of the longitudinal view with the final result. Take away points. All images, invasive or non-invasive, can be great in helping to recover a chip patient when it's down. In patient arrival with a chest pain, ischemic HEG changes, and cardiogenic shock, do not jump on the patient immediately if you have time. Take a breath and do a quick echo at the emergency room or in the cath lab is pivotal to be oriented and deciding strategy, ejection fraction, potential aortic stenosis, and mitral regurgitation. In presence of multiple life-threatening causes, make the priority strategy based on easy to be done and most quickly impactful. That was the reason to try to get this valvuloplastic first. Angiography continued to have a very limited sensitivity to calcium, and depending upon the view, you saw the difference, how much from RAO to AP cranial you can get it. Severe eccentric calcified lesion of the left main extending down to the LAD mandate, in my view, the use of imaging. Assessing calcium type, thickness, length, thickness, including also the minimum thickness, the response to lesion preparation, and the final stent results is a key. Actionable imaging, very clear and easy to interpret, and AI-driven software may simplify the action. Thank you very much for your patience.
That's an excellent case. Prashant, any comments? Chirag?
Yeah, fantastic case. I think, this sort of issue of significant coronary disease in the setting of severe aortic stenosis is a very interesting one. In our practice, we would have gone ahead and done the TAVR first. I mean, you did the balloon angioplasty, the balloon valvuloplasty first, and obviously that helped the cause. I'm just curious to understand, I mean, I think there's more than one way of doing this, but why did you not just do the TAVR up front, get that out of the way, and then proceed with the PCI?
Can you switch your mic on, please?
I think doing TAVR might also increase the level of difficulty at the ostium of the left main and the ostium of the right. And you might have some real challenge in getting in when you have both type of ostium involved. That was one of the decisions we taken.
Yeah, I think that's fair. Obviously, I think it depends on the specific height of the ostia and so on. And of course, if anatomically the struts of the valve would have impeded ostial access, then I completely agree with you. But regardless, at minimum, a balloon valvuloplasty first is essential. There have been many cases that we've seen where operators have not addressed the valve, either with valvuloplasty or with a definitive TAVR, and then during a complex PCI have got into trouble, either because of a broad vessel closure or perforation or something. And because of the severe aortic stenosis, patients have a very hard time recovering from that double hit. So just something to be cautious about when you have both of these things going on.
So one additional point is when we are doing TAVR, we wanted to do one time with a precise measurement in cardiogenic shock without having the guidance of the CT. It seems very hazardous doing such a similar type of implant. We wanted to get out from the shock as soon as possible and then eventually postpone the TAVR later on.
Makes sense.
No, great case, just
So the cardiogenic shock was due to the valve or due to the coronary artery disease?
Most likely, I think this looks like due to the valve because the lesions look more chronic, they are calcified. But just one point I agree with you, CT, if you have CT, it gives you the great liberty to size your balloon and to do everything. If you don't have CT, based on echo, your LVOT diameter, you can roughly give you some estimate. Or if you really want to play safe, because in someone who has a low EF, severe AS, and if you go with an aggressive balloon and if you have an AR, those patients crash pretty quickly. So if you really want to be safe, you can just do a 20 millimeter balloon or 22. I think you went with a 23 millimeter balloon. That's completely safe. Don't go too aggressive, just one balloon inflation. Get some flow in, do your PCI, and then always bring the patient back. To Prashant's point, you need a 14 French sheath to do the BAV. And, for TAVR, you essentially need 14 French expandable sheaths. So if the coronaries are too high, you can just do a balloon expandable valve if there is no compromise to the ostia, and then you can do PCI, but this approach is perfectly okay.
Thank you very much. So shall we go back to the live transmission? Can you switch back? Kirti, we are back to you. And
hey, thank you.
Yeah, would you like to show us what have we done since then?
Yeah, I'll tell you. Where did I leave you last? I think I did the rotablator and then left you, right? So take us back a few steps, notches back.
Kirti, I think when you left, you were just, put in a cutting balloon.
Yeah.
Right, exactly. So here we are. We go back to the cutting balloon. So we used a 3.0 by 6 cutting balloon. And we went and did cuts. We did various cuts in that segment, ranging from 16 to 20 atmospheres, very gradually going up. And eventually, through the entire lesion, in 2 fluoroscopic views, we saw complete expansion of that balloon with the uniform expansion of the balloon on both sides of the central wire. So we were very happy with our expansion. Based on our IVUS, it was just like 275 or 28 artery, so a little under 6.5 was our target destination distally. So based on that, we took and from the landing zone to the proximal ostium, it measured at around 25 millimeters. So I took a 28 millimeter stent, positioned it right at the ostium, a 3.0 in size, and I've just completely deployed the stent right now. And so you're ready for a picture just post-stent after the rota cut and stent. And of course, we will be optimizing the stent based on the IVUS, but those are the steps, basically.
It will look beautiful.
Yeah. And this was a 12 atmosphere deployment. I am going to take a 3.25 balloon NC and go up a little bit on the pressure. So give me a 3.25 NC. Any questions so far, please?
Comments?
No, I think great execution, when your atherectomy strategy and your thought process were slam dunk. Imaging really helped you to understand the lesion, chose the right burr. You didn't shy away from long burr time to achieve the good result, and this is a great result.
Yeah, angiographically looks fantastic, Kirti, and I assume you're doing some imaging post-stent?
So I don't want to do the imaging unless I do my basic expansion with what I thought I would do, because that way I reduce the amount of instrumentation in the coronaries. So I have taken a 3.25 And my whole idea is to expand the proximal 3/4 of the stent with a 325 at somewhere between 12 and 14, or maybe even go very gently to 16 atmospheres. And then I'll do an IVUS to see if I still need to optimize further. If not, if I get areas between 6.5 and 7 in this in this artery, I think I'm looking good. Okay, go up there, please. 2, 3, 4. 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Remember, this is oversized a little bit, so 12 is good enough over here. Stop.
Just watch the distal wire, otherwise everything looks great.
Yeah, thank you. Yeah, down. Go up there, please. Thank you. 2, 3, 4. Go to 10, and then go slowly up to 12, 13, 14, 16.
Do you stand this?
That's okay. Down. We've gone to the osteum. Too much radiation.
Okay.
Yeah, go up 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 16, 18. Down. IVUS.
IVUS.
And here you've got to be careful because you don't want your guide to go and hit that stent. So very carefully, I kind of take this balloon out into the guide because, you know, if the guide catheter dives in over here, that ostial location of that LED can get deformed a little bit. And that's the only caution, really. But if you'll bear with us, we'll give you an IVUS run right now because that will be the closure of the case.
Refresh.
We've used, how much contrast have we used so far? So totally we've used around 100 ml of contrast, including the diagnostic that we did, which is, I think, a little more than I would have liked, but.
Yeah, that's it. Okay, please. 0.5?
0.5 always, yeah. Unless it's ischemic, I do a 1.
Okay.
Put the lights down, please. Can everybody see the IVUS?
Yes, we see it.
Yes, yes.
Okay, good. Great. So we got a pull back going in. You can see the distal artery is looking okay.
Bookmark.
You can see the stent is exactly where we desired it to be. It's opened up okay. We'll do an MSA here, put a bookmark, measure the MSA here.
They did a bookmark.
As we come into the stent, we do an MSA here. This took us the longest time to rota next to that branch, so MSA here as well. And you can see it's well expanded, and I see that the stent looks at least 3, and it's circular. It's covering the entire circumference of the artery, circumference well. You can see the calcium has moved out. The broken calcium pieces are now separated out, preserving the lumen. So I'm very satisfied with what I've achieved on expansion and apposition. I'll just verify that. You can see 1 or 2 struts into that left main, which you'll see. Just wait, let it come there. I'll show it to you. Can you see that's the left main? And you can see just 1 or 2 struts maximum. And I think we should be okay there. Stop. We don't need more. Can I give me a couple of MSAs, please? And
distal edge MSA, distal bookmark, B1.
I think B3 and B2 are important because those are the calcified areas. We'll give you those MSAs.
Dr. Kirti, should we optimize the proximal stent to 3.5, the proximal part of the stent?
Show me the proximal part of the stent, please.
MSAs.
It's okay. It's okay. It's
no, really, no. I wouldn't do that because look at the MSA here. Look at the MSA. I don't see malapposition at all.
11.
And it's around 8.25. My desired was around 7 somewhere. I didn't want to do it any more than 7. Distally, it was 6.5 is my target. I've got a 5.6 as my MSA there. I think I'm looking good. I wouldn't stretch this anymore. I think this is good. We are going to get a good result for this.
Can
Anything
we
more than
use
this?
IVUS for the ostial placement of LED stent? We can put the IVUS to the LCS while placing the stent to the LED ostium. Do you?
I think that
practice it?
requires a lot of instrumentation, and I think we can do other things to make that better. I'm sure there are many ways to skin a cat, but
Kirti, what
I
did
don't know what others do.
what did the imaging look like at the distal stent edge?
Yeah, please, can you show them the
B1.
distal edge?
Show the B1. Yeah. Just go distally. Yeah, just go distally. Just show the distal edge dissection or not.
Please
There's no
enlarge the
dissection.
IVUS.
Can you see this is your distal just outside the stent area, which is okay. Yeah, just go 1 millimeter more. 1 millimeter more distal. Distal. There. That is your distal. Looks great. There's that plaque which was always there. There's nothing there.
Nice.
I'll give you some pictures. Oh, what am I done? Oh, I put it back in there.
Any further comments over there? Gulio or Praveer?
So I think that it was a great result, and after the injection, if Kirti can just turn the axis and show also in the longitudinal view how you can get the carina at the level of the
Give me the
bifurcation.
longitudinal, go to the circumflex, go to the circumflex. Show me the circumflex, take off.
And turn the longitudinal and show the carina.
Take the circumflex, go to the circumflex.
Proximal.
There. Now take the axis to down. Turn the arrow to 6 o'clock.
6 o'clock. No.
No, just the arrow. You're turning
Just
the
arrow.
whole, yeah, just the arrow. Go, yeah, inside, yeah. There.
Yes.
That's it.
Okay, and try to get the
Can you
visualization.
turn it out a little bit?
Okay.
More towards
Proximal.
7 o'clock.
So this is another chance that you have to get some information from the longitudinal view and the visualization of the carina, especially when you are dealing with this
Ariocaudal.
calcified
Give me a
vessel.
spider because the ariocaudal didn't contribute much really. I'm going to give you a spider. We want to see that big diagonal branch, unrestricted, go out. LAO, get me off the spine. A little more. That's it, that's good. Center.
Beautiful. Looks.
Well, that's a great angiographic picture. There's no doubt.
I think it looks great. One can argue and say we can open up the struts towards the diagonal branch because it's huge. One can do that, and I am going to do that if I can. But otherwise, I don't need to do anything further to this LED stent. Would everybody agree?
Yes, Dr. Kirti Punamia and Dr. Nishit Chandra, the panel over here is all unanimous that this was a beautiful case and very well demonstrated and good strategy. A big hand to you while we move off from Escort Strategy. Thank you.
Guys.
So we'll take a break now for today and we meet up tomorrow morning at 9. But before that, in another hour, maybe at around 8:30, we are back again over here and you'll find a different room with a nice band. We can loosen ourselves and break off whatever so much of information we have got inside our heads. So thank you very much, all of you, for this session, the panelists, the chairpersons and the moderators, and excellent cases and discussions. Thank you.